All right, this is the warm-up for Pediatrics 4. First question, what is cradle cap and what's the treatment? So cradle cap is seborrheic dermatitis. We're going to treat that with selenium sulfide shampoo, or you could also use topical antifungals. Next, what's the cause of bilious emesis in a newborn within hours after the first feeding? That's a classic presentation of duodenal atresia. The third question, what are the two most common primary brain tumors in adults? Remember, the mnemonic for adult brain tumors was MGM studios. So the first M is metastasis, so that's not a primary brain tumor. G is for glioblastoma, which is the most common primary adult brain tumor. And the second M is for meningioma, which is second most common. And S, the third most common primary tumor, would be a schwannoma. Schwannoma, S for studios. And then what are the three most common primary brain tumors in children? Think about astrocytoma, medulloblastoma, and ependymoma in that order. So that's the end of the warm-up. Let's get started with the lecture.
In this video, we'll discuss pediatric genetic disorders. Now, we have a lot to cover in this video, and most of what you need to remember for your Step 2 exam is 3 or 4 high-yield facts for each of the topics we'll cover today. With this content, the concepts aren't difficult, but the memorization of the facts becomes more important. Let's start with Turner syndrome. It's the first disorder we'll discuss. It's very likely to be on your test. The H&P includes short stature, infertility, abnormal genital formation, increased incidence of renal and cardiac defects such as coarctation of the aorta. It has also craniofacial abnormalities including protruding ears, webbing of the neck is a big clue, and low occipital hairline. The neck webbing can be seen at birth, so you might possibly see that on your test. Also, be able to recognize that Turner syndrome has the 45XO karyotype. You might remember the Step 1 mnemonic for Turner syndrome, which was hugs and kisses, or XO, from Tina Turner. This is the most common cause of primary amenorrhea, so make sure you know that as well. Sometimes test questions will have a short stature young woman without some of the other striking features, and they present with just the primary amenorrhea. So be on the lookout for that type of question as well. The lab work for all of these sex chromosome disorders includes karyotyping, which will reveal an abnormal number of sex chromosomes. This is also important when working at primary amenorrhea. The treatment for Turner syndrome requires regular cardiovascular assessments and estrogen and progestin replacement. We also often give growth hormone to augment height in these patients. For the most part, with all of these sex chromosome disorders, patients are generally able to live a pretty normal adult life. Most pregnancies with a 45XO karyotype end in spontaneous abortion. First trimester abortions tend to be due to chromosomal abnormalities like the 45XO karyotype. Next, let's talk about Klinefelter syndrome. Klinefelter syndrome is a 47XXY karyotype. So these are males that have an extra X chromosome, and they tend to be more female in appearance. On H&P, these patients are males with testicular atrophy, tall and thin body, gynecomastia, infertility, mild intellectual disability, and psychosocial adjustment abnormalities. Here you can see a tall, thin body with gynecomastia in a patient with Klinefelter syndrome. Next, we'll move on to the XYY male. This is a male that has an extra Y chromosome. They have a tall body, over 6 feet tall, significant acne, and only some of them have mild intellectual disability. Now, the physician community used to think that there was a higher incidence of criminality among these males, but this is actually not the case. Moving on to XXX syndrome, here you have a female with an extra X chromosome, giving her the karyotype 47XXX. Some intellectual disability can be present. Patients tend to score 15 to 20 points lower on an IQ test than their siblings. And these patients will also have some menstrual abnormalities. The other unique thing with the XXX female is that they tend to be in the 80th percentile for height, but only in the 25th percentile for head circumference. Next up are the trisomies. These occur because of autosomal non-disjunction. Chromosomes are unequally being distributed, or due to genetic translocation during sex cell production that results in extra copies of autosomal genetic material. Trisomy 21, or Down syndrome, is the most common of the 3 trisomies that we'll discuss. On HMP, you're going to see craniofacial abnormalities, including protruding tongue, flat nose, and small ears, as well as vision and hearing loss, and broad hands with simian crease, which you can see in this image. Then you can also have intellectual disability, cervical spine instability, increased space between the first and second toes, increased risk of duodenal atresia and other GI abnormalities like Hirschsprung disease, which initially presents with failure to pass meconium, possibly annular pancreas, possibly celiac disease. These patients also tend to get Alzheimer's disease in their 30s, and they also tend to have cardiac defects. Now, Down syndrome patients usually survive into the 4th decade of life or possibly longer. What is the cancer associated with Down syndrome? This is ALL, and one way to remember that particular cancer association is the last line of the Ring Around the Rosie song, all fall down. Additionally, there is a small increased risk of AML in Down syndrome as well. Now, what do you see in the first trimester ultrasound with the Down syndrome? Well, what you're going to see with the ultrasound is nuchal translucency, so make sure you know that. So in addition to the ultrasound, another way to screen for Down syndrome is with the quad screen. The pregnancy screen will include a decreased alpha-fetoprotein level, increased beta-HCG, decreased estriol, and increased inhibin A. Again, decreased alpha-fetoprotein level, increased beta-HCG, decreased estriol, and increased inhibin A. So make sure you know that associated with Down syndrome. If you see that combination on a pregnancy quad screen, it's a red flag, huge flag for Down syndrome. It's not diagnostic, but it is a big flag. Trisomy 18 is Edwards syndrome. It occurs in 1 out of 6,000 live births, so this is about 10 times less common than trisomy 21. With trisomy 18, you have severe intellectual disability, small mouth called micrognathia, limb abnormalities such as malposition, rocker bottom feet, overlapping fingers on grasp. Possibly you can have cardiac defects, GI abnormalities, and it's frequently fatal within the first year of life. Just like with Turner syndrome, a lot of these patients will miscarry in the first trimester. Trisomy 13 is Pateau syndrome, which is also very uncommon. With this, you tend to have a cleft lip and palate, cardiac defects, CNS defects, severe intellectual disability, rounded nose, polydactyly, and it also is frequently fatal within the first year of life. The lab work includes karyotyping to detect extra chromosomes. The prenatal quadruple screen or quad screen can help detect potential affected fetuses, and amniocentesis can be used to confirm the diagnosis. Next up is deletion syndromes. These are diseases that result from deletion of all or part of an autosomal chromosome. The main thing here is being able to make the diagnosis in these syndromes. First, let's talk about Cri du Chat. Here is an image of a patient with Cri du Chat. It may not be obvious here with these patients, but they have a small head, low birth weight, intellectual disability, and failure to thrive. Cri du Chat is really easy to identify on your test because they're almost obligated to put the high-pitched cat-like cry in the question stem in order to make it diagnostic of this particular disease. Everything else is pretty non-specific for Cri du Chat, but if you see that high-pitched cat-like cry, you're able to make the diagnosis on your exam. As far as memorizing the chromosomes, I wouldn't get bogged down in memorizing which chromosomes are associated with each of these disorders. Another disease, Wolff-Hirschhorn syndrome, is worth at least mentioning. It's associated with intellectual disability, multiple cranial abnormalities, and seizures. I don't think it's a very high yield for your test, but it's just, like I said, worth mentioning. Prader-Willi is the one where you have overeating and obesity. This is also associated with decreased muscle tone in infancy. So sometimes these patients will have a really hard time feeding in infancy. They also have intellectual disability, small hands and feet, and obesity-related complications that can decrease their lifespan. This is inherited on the chromosome from the father. So Prader-Willi patients are either male or female, but the inheritance is from the father. Seems like that, typically you see males in images of patients with Prader-Willi, but females can get it too. Now, Angelman syndrome can be either a male or female problem as well, but the defect here is inherited from the mother. So it's the same chromosomal problem as with Prader-Willi, but it's inherited from the mother instead of the father. Angelman is referred to as happy puppet syndrome and is associated with happy mood, intellectual disability, inappropriate laughter, and an ataxic gait similar to a marionette puppet. Moving on, velocardiofacial syndrome. This is a 22q11 deletion. It's associated with DiGeorge syndrome. Also, these patients have a cleft palate, cardiac defects, mild intellectual disability, significant overbite, and speech disorders. Early mortality can result from associated cardiac complications or DiGeorge syndrome. And you might remember DiGeorge is characterized by T-cell deficiency and hypocalcemia. Another one I want to throw in here is Williams syndrome. What is a classic facial description of someone with Williams syndrome? This is an elfin-type face with a short upward turned nose and a long philtrum. These patients tend to have mild intellectual disability and are cheerful and have associated cardiac defects. All right, moving on, Fragile X syndrome. So this is an X-linked chromosomal disorder associated with intellectual disability in males. Females may be carriers, but rarely show any effects from the abnormal gene. This is a trinucleotide repeat disorder, so they have a CGG codon that repeats, and this shows anticipation in successive generations. So it's going to occur earlier and be more severe with each successive generation. The HMP shows a large face with prominent jaw and large ears, mild hand and foot abnormalities, large testicles, macroorchidism, intellectual disability, hyperactivity, and possibly seizures. Now, Fragile X syndrome is one of the most common causes of congenital intellectual disability in men. So you can detect this with genetic screening, and appropriate education and monitoring is always needed here. Congenital malformation is not yet discussed. Now, we have a batch of high-yield questions in the study guide that we need to go through. What is the most common malformation of the head and neck? This is a unilateral cleft lip. Cleft lip is associated with cleft palate, but you can have either one of those alone, or the two can be associated with each other. This is caused by multiple different factors, but folate supplementation does reduce the incidence of cleft lip and cleft palate. Next question. What features are characteristic of fetal alcohol syndrome? Facial features include short palpebral fissures, thin upper lip, smooth philtrum, and flattened midface. There is deficient brain growth, characterized by structural brain abnormalities, less than 10th percentile for head circumference, abnormal neuroexam, and variable intellectual disability. There's also growth retardation, characterized by less than 10th percentile for height and weight, failure to thrive despite adequate intake, and disproportional low weight to height. Next question. What congenital defect is associated with lithium use during pregnancy? This is the Ebstein's anomaly. Here you have tricuspid leaflets that are displaced into the right ventricle. There's a hypoplastic right ventricle and tricuspid regurgitation or tricuspid stenosis. 80% have a patent foraminovalle with a right to left shunt. There's a dilated right atrium leading to an increased risk of SVT and WPW or Wolff-Parkinson-White. On physical exam, you may hear a widely split S2 and tricuspid regurg. Next question. What are the differences in presentation between a brachial cleft cyst and a thyroglossal duct cyst? The brachial cleft cyst is present in the lateral neck. The thyroglossal duct cyst is in the midline neck. It moves with swallowing and is the most common congenital neck cyst. It's very commonly associated with also ectopic thyroid tissue. Next, what are the common possible presenting features of tuberous sclerosis? Now, there's a range of presentation with tuberous sclerosis, and not all of these patients have all of these findings. But some of the characteristic findings include distinctive brown fibrous plaques on the forehead seen in infancy, ash leaf spots. These are hypopigmented macules, most easily identified with Wood's lamp. They might have a chagrin patch, which is a leathery cutaneous thickening, usually on the lower trunk. They might have facial angiofibromas, also known as adenoma sebaceum. They might have seizures. They might have intellectual disability. And these patients can also have subependymal nodules in the brain, which may be an important clue to help you distinguish tuberous sclerosis from neurofibromatosis. Next question, which glycogen storage disease matches the following statements? You need to be able to recognize these and diagnose these on step 2 exam. All right, so lactic acidosis, hyperlipidemia, hyperuricemia resulting in gout. This is type 1 von Gerich's disease. In this disease, the liver cells cannot undergo gluconeogenesis. Diaphragm weakness leading to respiratory failure. This is type 2 Pompe disease, the adult form. Increased glycogen in the liver resulting in severe fasting hypoglycemia. This is type 1 von Gerich's disease. Hepatomegaly, hypoglycemia, hyperlipidemia. Here the kidneys are normal, the lactate and uric acid is normal. This is type 3 Cory's disease. Painful muscle cramps, myoglobinuria with strenuous exercise. This is type 5 McArdle's disease. Severe hepatosplenomegaly and large kidneys. This is type 1 von Gerich's disease. So just know the presentations of those different glycogen storage diseases. That's all you really need to know about those diseases. So you don't have to get bogged down with more details than what we just discussed. All right, it's time for the end of session quiz. Go ahead and pause the video, answer the questions as best as you can on your own, and then we'll go through the answers together. First question. If a female child is in the 80th percentile for height and the 25th percentile for head circumference, what chromosomal abnormality should you suspect? You would suspect the triple X syndrome where this patient has a 47XXX karyotype. Next question. What genetic disorder matches the following description? Cleft lip and palate, life expectancy less than 1 year, polydactyly, that's trisomy 13. High-pitched cat-like cry is Cree de Chat. Elfin facial features with cardiac defects. This is Williams syndrome. A tall, thin male with gynecomastia and testicular atrophy. This is Klinefelter syndrome. Obesity and overeating is Prader-Willi syndrome. Micronathia, life expectancy less than 1 year, and rocker bottom feet. That's trisomy 18. Happy mood, inappropriate laughter, and ataxic gait. This is Angelman syndrome. Large ears, intellectual disability, and macroorchidism is Fragile X syndrome. Intellectual disability, semi-increase in GI and cardiac defects. Here you have trisomy 21, Down syndrome. Short stature, infertility, and coarctation of the aorta is Turner syndrome. Next question. A child presents with short palpebral fissures, a thin upper lip, smooth philtrum, and a flattened midface. He is below the 10th percentile for height and weight, and his IQ is 65. What is the cause of his abnormalities, and what could have been done to prevent them? So this is a classic presentation for fetal alcohol syndrome, and of course the prevention would have been for the mom not to drink alcohol while she's pregnant. And the last question, which glycogen storage disease matches the following statement? Lactic acidosis, hyperlipidemia, hyperuricemia causing gout is type 1 von Gerich's disease. Diaphragm weakness leading to respiratory failure is type 2, it's the adult form of Pompe disease. Increased glycogen in the liver, severe fasting hypoglycemia is type 1 von Gerich. Hepatomegaly, hypoglycemia, hyperlipidemia, but with normal kidneys, normal lactate, and normal uric acid. So it's not von Gerich's because those findings are normal. This is type 3 Cory disease. Painful muscle cramps and myoglobinuria with strenuous exercise, pretty benign disease, type 5 McArdle disease. Severe hepatosplenomegaly and large kidneys, this is type 1 von Gerich's disease. All right, that's it for this lecture. And this is my last Step 2 lecture for this year's course. It's been an honor. Thanks for choosing Doctors in Training to help you with your studying. I'm sure you're going to do great on your test.